I'm Nanda. I'm one of the interventional radiologists at Singapore General Hospital. I'll be speaking on Angio-CT used for complex procedures for drainages, biopsies, and radiofrequency ablations. Nothing to disclose. So just start off with a bit of history. The hybrid Angio-CT system was developed way back in 1992 in Japan by Professor Arai, who was from National Cancer Center. We've been lucky to have the first Angio-CT, which was installed in Singapore in 2008. Since then, we've had the second Angio-CT, which was installed last year. So it's a hybrid Angio-CT system, which is a combination of two modalities in the same room, which share the same floating tabletop. They can be used either in conjunction or independently. So the angiography system has got a C-arm, which is suspended from the ceiling, and a flat panel detector, and can perform both stepping and rotational digital subtraction angiography, and also capable of cone beam CT. The CT system, we have a 16 slicer and a 160 slice self-propelled multi-slice CT, and the gantry aperture is 72 centimeter. It's capable of performing real-time multi-slice CT fluoroscopy, which enables a multitude of complex procedures. So they've got several configurations, and 3 of them are brand new in the market. So this is our setup at Singapore General Hospital. This is our Angio-CT suite, and you can see the C-arm here, which is suspended from the ceiling, and the CT gantry here. And they both share the same tabletop where the patient, you can see the patient there, and which can move forward and backwards. And also the CT gantry can move into position to scan the patient and can be pushed back. So this is the control room, which is situated outside the angio room, and you can see monitors separately for the angiography and for the CT system. And also we got a dedicated workstation for reconstruction purposes. So our workflow for most of the procedures where the procedures need the combination of angio and CT is, for example, in this case, this is a patient who's having hepatic angiography for mapping before the Y90 procedure. So the microcatheter is placed in the right hepatic artery. Subsequently, the catheter is connected to the CT injector. The initial procedure is obviously performed in the fluoroscopy or the angio system, and then once the catheter is connected to the CT injector, the fluoroscopy C-arm is moved away to a safe position, and then the table is moved forward, and then the CT gantry is brought back into position, and then we all come out and then review the preliminary digital subtraction angiography, which will help us to determine the scan delay and also the other injection parameters we need to perform the CT procedure. So then subsequently we do the CT angiography, and then all the post-processing is done outside. So obviously, there are distinct advantages when we use Angio-CT. I'm going to show you the difference between the suite we have, which is the hybrid Angio-CT, and also the one without using Angio-CT, the workflow difference. So with an Angio-CT, especially when you're doing something like the hepatic angiography, which I showed you on the previous slide, once we've done the angiography and place the catheter at the suitable position, we just have to move the table backwards and move the CT gantry into position, do the CT scan, and then pull the table backwards and move the gantry out, and we can continue with the rest of the procedure. And overall, the estimated time for this entire process takes around 5 to 10 minutes, but with practice, it can be done by less than 5 minutes. However, if you don't have this system, the workflow is going to be something like this. After the initial angiography, the patient from the angio table has to be transferred onto a trolley and then moved to pushed to the CT room, which can be at least a 5-minute walk or sometimes longer, and then transfer the patient onto the CT table and then the patient undergoes the CT scan, which is the intra-arterial CT angiography, for example, and then the patient has to be transferred back to the trolley and then back to the angio room to continue the procedure. Overall, this might take somewhere between 45 minutes to 1 hour, or sometimes even longer. So just to show a video of how the hybrid system works. So you can see the shared tabletop, which can be moved backwards and forwards, and the CT scan is performed. Once the CT images are acquired, the gantry is moved out and the table is brought back into position, and the C-arm, which was docked in safe position, is brought back, and you can continue with the rest of the angiography procedure. People might question that we can do the same, the entire procedure using the combination of angio and cone-beam CT, which is available in most places. However, there are significant differences between the two setups. With Angio-CT, there are several advantages, like it's easy and much faster than doing a cone-beam CT. The field of view or the coverage is much larger. The coverage is also flexible. Artifacts are significantly less compared to that of the cone-beam CT, and you can acquire multiple phase CT scans, which will help to confidently make diagnosis of tumors like hepatocellular carcinomas, which can sometimes be quite difficult when you use a single phase injection, which you can do with cone-beam CT, and max you can do with cone-beam CT is two phases. Also, the breathing instruction is less important with Angio-CT because it's very fast. The entire scan can be done in a couple of seconds, as opposed to cone-beam CT, where the patient has to really breath hold. This can be a significant problem in patients who are unwell and where they can't really breath hold, which can cause significant artifacts to the extent that the images can be completely degraded and of non-diagnostic quality. And also the dose compared to the cone-beam CT is less. So there are obvious advantages of using this hybrid system compared to the cone-beam CT. So I'm going to share some complex procedures where we've used this hybrid system to do this procedures. I'm going to start off with a radiofrequency ablation, where the procedure warranted vascular occlusion to prevent tumor recurrence from heat sink effect. So it's a 77-year-old female who had NASH-related Child-Say cirrhosis, complicated by portal hypertension, varices, and previous upper GI bleeding previously. So this patient had multifocal HCC and had progressed on TACE, and she had two tumors which had progressed after two sessions of TACE. One of them was abutting the intrahepatic IVC. The other one was in segment 8, but still far off from many major vascular structures. So the one which was away from the vascular structures was targeted under ultrasound and was ablated without any issues. However, this is the other tumor which I'm talking about, is the tumor which sits next to the intrahepatic portion of the inferior vena cava, which shows rim enhancement and washout on the portal venous face. And this was the lesion we were worried that can have marginal recurrence because of the heat sink effect. So we decided to occlude the flow within the IVC and then perform the radiofrequency ablation. So as you can see here, this lesion was difficult to see on ultrasound, so we used the CT fluoro system to target the lesion and position our needle within the tumor. And prior to this, we accessed the right femoral vein and placed a coda balloon within the infrahepatic portion of the vena cava. And during the ablation, we occluded the IVC, inflated the balloon and occluded the flow within the IVC. So, and post ablation, this is an unenhanced CT scan which shows the ablation zone. A CT was performed the following day, and this is the CT on the following day. On the arterial phase, you can see the expected ablation changes, and there is no arterial hypervascularity to suggest any residual disease. The patient subsequently underwent a CT scan 4 months later, which still shows a good ablation zone with no evidence of tumor recurrence, and also a fully patent IVC without evidence of any significant injury. So without the availability of this hybrid system, this procedure would have taken much longer and more difficult. So I'm going to show you another case where we use this hybrid system to do a complex drainage. We had a 55-year-old male with acute history of abdominal pain and sepsis. So his diagnostic CT showed a complex collection in the right upper quadrant, abutting the hepatic flexure, the liver, gallbladder here, and also medially by the pancreas and the duodenum. There was only a very narrow window to access this collection. So again, coronal reformats of the diagnostic CT shows the location of this abscess with critical structures adjacent to the collection. So we do a preliminary CT as before the procedure with the markers on the skin to localize the collection, which is here. And then subsequently, under live CT fluoroscopy, or intermittent CT fluoroscopy, we advance the access needle into the collection. And you can see the needle in the collection, avoiding all the important structures which I just showed. So once the needle is in position, we inject a bit of contrast to confirm the position of the needle within the abscess. Subsequently, the rest of the procedure was performed under fluoroscopy. Fluoroscopy was definitely warranted in this case because we wanted enough guide wire coiled within the abscess collection, which would give us enough support to do the subsequent procedure like tract dilatation and also insertion of the catheter. So as you can see here, to ensure that we had enough guide wire, we got in a diagnostic catheter and pushed in quite a lot of wire and looped quite a bit of wire within the central part of the collection, and subsequently deployed the catheter, ensuring all the side holes of the catheter are localized within the collection. This ensured complete drainage of the complete drainage of the abscess. So also a CT was performed immediately after the drainage, and you can see there the injected contrast has also flown into the colon, large colon, suggesting that obviously there's a communication between the collection and the large colon, and this was due to a perforated diverticular abscess. This is another example of a complex drainage performed using the hybrid Angio-CT system. So this patient had pancreatectomy, and there's a large pancreatic collection in the collection in the pancreatic bed. And also you can see a graft here, which is a portal vein graft. So this collection partly encases the graft. So we had to ensure that the drainage catheter was all the way sited close to this graft to ensure complete clearance of the infection at this site to ensure adequate healing. So again, that's a coronal reformat showing the graft and the pancreatic bed collection. So under CT guidance, or intermittent CT fluoro, we could pass the access needle into the collection and injected a small amount of contrast to ensure the needle position is satisfactory, and the rest of the procedure was performed with great confidence using the fluoroscopy system or the angio system. So we could direct the guide wire all the way close to the graft, and then subsequently after tract dilatation we could insert the drainage catheter and position it very close to the graft, which ensured complete drainage of the abscess, and patient did well after that. So I'm going to show you another interesting case where this hybrid system was extremely useful. So this patient has got a mass posterior to the right psoas muscle. So the patient is prone here. So, and you can see this is a preliminary scan with the markers on the patient's skin posteriorly. So we advanced coaxial needle, which is a 17-gauge needle, under intermittent CT fluoroscopy, and subsequently took a course using an 18-gauge biopsy needle. Immediately after the procedure, we saw brisk bleeding coming off the coaxial needle. So we knew that the biopsy needle has transgressed branch of the lumbar artery, which is likely the culprit or likely the cause for this brisk bleeding. So we connected, decided to use fluoroscopy and injected contrast via the coaxial needle. And this clearly shows opacification of the lumbar artery branches and also laceration of the branch of the lumbar artery and active bleeding. So attempts were made to coil the culprit vessel via the same coaxial system, but was not successful. So immediately we could turn the patient on the table from prone to supine position, access the right femoral artery, and cannulate the culprit bleeding lumbar artery, and this was successfully embolized, resulting in hemostasis, and the patient also stabilized. So this is something new which Toshiba has brought in with their new versions of their Angio-CT system, which is called one-volume CT. So it's got an ability to acquire isotropic volumes of an entire organ with a single rotation of the gantry. So it's all non-helical images, and the scan provides quite exquisite motion-free images. And our system, where we have the 160 slice CT with single exposure, we get a block of 4 centimeters of the organ or the body. So when we do this, we try and cover the target nodule or the intended biopsy site. And it also gives you instant multiplanar reconstruction, which can be extremely useful for needle guidance to be quite precise to target a very small lesion. So I'm going to share a couple of cases using this tool. So we have a small left lower lobe pulmonary nodule. As you know, left lower lobe nodules are quite challenging to biopsy. So this is the initial scan with the patient prone with the markers on the skin. And under intermittent CT fluoroscopy, we could advance the coaxial needle close to the nodule, and a one-volume scan was performed, and which gives you basically reconstruction in all 3 planes: axial, sagittal, and sagittal oblique, and coronal plane, which shows that the needle is directed, the needle position is accurate, and if I push in my biopsy needle via the coaxial and biopsy, I would get a good core of the nodule. So once I was happy with the needle position, I could advance the biopsy needle via the coaxial and get satisfactory cores, which are of diagnostic yield. So this is another difficult biopsy. This patient has got, again, a left lower lobe nodule with central cavitation. Obviously, in this case, you want to sample the peripheral solid component and avoid the central cavitated portion, and use of one volume with 3 plane reconstruction gives you more confidence to direct the needle precisely to the solid component. As you can see here, once I place the coaxial needle into the peripheral part of the tumor, avoiding the central cavitated portion, I did a 1-volume CT, which shows me the needle position in the sagittal plane or the sagittal oblique, coronal plane, and subsequently could confidently biopsy the solid component. So this is another case where you can see a sub-centimeter ground glass nodule within the left lower lobe. This patient was for wire localization and subsequent resection of the tumor by the surgeons. So using this 1-volume scan, we could precisely place the localizing needle within the center of the lesion, and subsequently the patient went to theater and the tumor was resected, which proved to be a minimally invasive adenocarcinoma. And you can also get quite elegant 3-dimensional reconstruction showing the needle going through the center of the nodule, which is quite appealing for some of the clinical colleagues. So in conclusion, hybrid angio system definitely has got advantages compared to your cone beam CT. It can facilitate some really very complex radiological percutaneous intervention, certainly improves operator confidence, and can mitigate and reduce some of the complications, and also can give you a precise or can delineate the anatomy quite clearly which can enable you to perform some of the complex interventions quite safely. Thank you very much.